Hey guys, so today we are getting deeper into our lower respiratory disorders lecture, and we're going to focus on tuberculosis. So, compared to pneumonia, tuberculosis is always a bacteria, and it's always the same bacteria. Tuberculosis is, caused by a bacteria known as Mycobacterium tuberculosis. It is effectively similar to you're going to see a lot of stuff similar to pneumonia as we talk about tuberculosis, but start trying to pick up on what some of those differences are. So, like, for example, with tuberculosis, it usually only involves the lungs, but it can spread to other organs. Tuberculosis can be latent or active, which we'll talk about the difference there. And whereas pneumonia is what do you call it? It can be spread different ways and things like that, but it's not an airborne disease where tuberculosis is. And so airborne means all I have to do is be in the same space as someone, whereas with pneumonia, a lot of times, and I mean, even people with pneumonia aren't usually in isolation at all. But airborne isolation is has a higher transmission rate than what you might see for pneumonia. So, I'd be worried a lot more with pneumonia about, their sputum and their droplets and things like that. And I'm not saying it's droplet precautions, because usually people with pneumonia are not in isolation at all. But it's not the same kind of transmission. So, with tuberculosis, it is an airborne transmission. So that means I could be in a room with this person, and if they're breathing, talking, singing, sneezing, coughing, and I have, close, frequent, prolonged exposure to them. And of course, depending on my immune system, how many organisms they have within them, it's going to depend on how much that's going to spread. But just start looking at some of these differences, how it spreads. It can spread more in the body. There's this latent versus active component, in that the transmission is different. Excuse me. It's not to say that, like a person with pneumonia can be in the same room with a person and spread it as well. But there is an isolation needed for tuberculosis, where we usually do not isolate pneumonia patients. All right, so who gets pneumonia? So people that, sorry, I'm going to say this backwards. Who gets tuberculosis? Just kidding. Who gets tuberculosis? So people that get tuberculosis are those that, live or work in congregated areas. So think a lot like we talked about for influenza. So like healthcare workers, people that work in prisons, or obviously, I was going to say prisoners in prison, or they could also be those that are living in a long-term care facility, and when I say living in a hospital, I mean, as a patient. But yeah, as a whole, think of people that are very in close quarters with each other, or those that have weak immune systems. So we worry about those that have HIV, those that have a lot of IV drug use, because they'll be higher risk for getting HIV that would suppress their immune system, people that have unsafe sex practices, people that are already immunocompromised because they might have an autoimmune or other disorder, and the homeless population, because of the nature of their living situation. And many of them also have those other risk factors like, HIV and other chronic illnesses. We want to think about those people as being more at risk for tuberculosis. Let's do a true or false with tuberculosis to talk about this latent versus active. So I'm going to talk about it more on the next slide, but let's see if we can get through this. So this is a great way to kind of do some knowledge practice and try to see what we already know about latent versus active tuberculosis. So let's say that I just know the basics, that I don't know a lot, that if there's active tuberculosis and then there's latent. So latent seems like it maybe happens later. Maybe. Let's try with that. So does a patient with latent tuberculosis need to quarantine for 2 weeks? So if it's latent, and it's not active, it seems like maybe that's something where they do not need to quarantine at all, because maybe they don't actually have tuberculosis right now or can't spread it. So I'm going to say false for this one. The client will not need any treatment as long as they are not actively infected. So even though that sounds like it might be true, I feel like if you have tuberculosis at all, you're going to need some sort of treatment. So I'm going to say false for that one too. The client will need to wear supplemental oxygen as they recover. So this is not an active process. I'm going to think that they're not going to need any sort of additional treatments. We're talking about needing supplemental oxygen. I don't know if they have any symptoms with latent tuberculosis. So I'm going to say false for this one too. So then I'm down to the client will most likely always test positive on a TB skin test. Well, I think if they have any type of tuberculosis, they're always going to test positive. So I'm going to say true for this one. And then the client's tuberculosis can become active at a later time. Well, it's kind of like in the name, it happens latent or later. So it seems like that would be true as well. So I think false, 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 true, true. Let's read more though about latent versus active. So latent tuberculosis, what's happening here is effectively maybe I'm a healthcare worker, I'm exposed to tuberculosis from one of my patients. They don't know that they have tuberculosis, or I didn't know they had tuberculosis. So, I was in close contact with them and they exposed that to me. I'm a young, healthy person. I like to think, at least, I'm hoping being in my 30s still considers me to be young, but everything changes now these days. But let's say I'm a young, healthy person and I don't have any other chronic conditions, any other issues that would put me at risk for not being able to defend myself against an infection. My body can probably go in and take all that bacteria that's in my lungs that that other person spread to me, and they can kind of pretty much encapsulate it or steal it away and hide it in my lymph nodes and in my lymph area, and pretty much think of it like it is effectively, I'm trying to think of the word that I want to use that would make the most sense, that's simple instead of saying encapsulate. It's pretty much hiding it away. Like it's putting it away. It's saying like, hey, it sees the bacteria. It's able to overcome, it overtakes the bacteria. The bacteria doesn't overtake my body. Effectively, my immune system is strong enough to take down the bacteria. Now, it can't get rid of it. So what it does is it effectively, these cells eat it up, and then those cells go and hide in my lymph area. And when I say hide, I mean they go to that lymph area and pretty much store away this bacteria now, because they can't fully get rid of it. But what that means is that I don't, the bacteria is gone. I can't actively spread it because it's not even in me. I can't give it to someone else. So I'm not having any active symptoms, and I'm not dealing with any problems from it. However, it's still at a later time. Let's say later in my life I get cancer and I need to get cancer treatments. My immune system is compromised. Those bacteria could be released at a later time. So effectively, they're kind of hidden away for now, but they could come back at any time. So if I have latents, these bacteria are hidden away, I can't spread this to other people, but I still have tuberculosis. I've been exposed to it. So I'm going to need treatment. It's just not going to take me, I don't need as long of treatment as people with active tuberculosis. Now, I've been exposed to tuberculosis, so my immune system has built up a response against it. Therefore, my TB tests are always going to show up as positive. And again, like I said, at a later time, if I'm immunocompromised or something happens with my immune system, it can become active later and get released. Whereas with active tuberculosis, that would be the other side of that would be like, let's say that my immune system doesn't have the defense to fight against tuberculosis. What would happen at that point is that if my immune system gets overwhelmed by tuberculosis, because we'll kind of think of this like the tuberculosis is stronger than my immune system, or I have a weak immune system, therefore tuberculosis is going to be stronger. Then I have active tuberculosis. It can't encapsulate it and hide it away, and I have the ability to spread the tuberculosis to other people. I'm actively infectious and I'm going to require long-term treatment. My tests are, of course, going to be positive, but the other thing that's going to be different between active and latent is that, and I talked about with latent that all their tests are going to be positive, but except for culture. I forgot to mention about this. So we'll talk about the diagnostic tests here next, but there's 4 possible tests that a patient can get. They can get a skin test, they can get a blood test, they can get a chest x-ray, or they can get a sputum specimen. For a patient with latent, there's TB skin test and their blood test. are going to show up positive because they've had an exposure and their body has built up a defense. But their chest x-ray is going to probably be negative because they're not actively fighting any infections. They don't have any symptoms. And their sputum is going to be negative because there's nothing growing right now. All that bacteria is encapsulated and hidden away in their lymphatic system. Or with active tuberculosis, they're going to have positive probably for everything. Their TB skin test is going to be positive. Their T-spot or their blood test is going to be positive. They may show abnormalities on their chest x-ray, and they're going to have a positive sputum culture. And that's because actively right now growing within my body is going to be that Mycobacterium tuberculosis, because right now my immune system cannot encapsulate it, cannot hide it away. It is here actively causing a problem. So hopefully that makes sense. So effectively latent, they can't spread it, but they need treatment. Their skin test and blood tests are going to be positive, but their sputum is going to be negative, and later on it could become active. Whereas with active, it can spread. They need long treatment. All their tests are positive, including the sputum culture, and they will show stuff on their x-ray. So how do we diagnose tuberculosis? How we do this, like I mentioned, there's a skin test, a blood test, an x-ray, or sputum. Now, we usually do not use any of these alone, except for, we're not going to usually use any of these alone. Like even if the best golden standard measure is going to be a sputum specimen, but it doesn't mean that that's the only test that we're going to get. So most people are familiar with the skin test. This is like where they do like an intradermal injection and they're looking for some sort of induration. Now for my school, you do not have to know the different levels of induration, but it's like a raised hardened area or swelling at that injection site. But the problem with this one is that there's two issues. One, it requires that a person gets the test and then comes back within 48 to 72 hours. And this can be hard to schedule at times. And the other problem is that it can have reader bias. So the person reading it, depending on their eyesight, their opinion, things like that, they can have different results. So the other test that has been started to be used more often, however, is more expensive, is going to be the T-spot, which is a blood test. It doesn't require a follow-up. They don't have to come back. There's no reader bias. It either is positive or not. And the other thing is it's not affected by the BCG vaccine. And what this is in certain countries like Europe, tuberculosis is a little bit more common. So they get a vaccine for tuberculosis. So therefore, if I had a vaccine for tuberculosis, and then you test me for tuberculosis, my immune system has built up a defense against it. So it's really hard sometimes to get an accurate measure. And a lot of times, these people with BCG had to get like regular chest x-rays and stuff to prove that they don't have tuberculosis, because everything else is going to show up as positive. But per our most recent textbook, it says that the T-spot is not affected by that vaccine, which is a great thing, so that we can know whether someone who's had a BCG vaccine has active tuberculosis or has, they've been exposed in a new or different way. Aside from the vaccination. So with chest x-ray, we usually do those for, like I said, for those that receive the BCG vaccine. But just know, like a chest x-ray, it's not a definitive. I can't look at an x-ray and be like, that's tuberculosis. But if someone has no symptoms and you can look at their x-ray and say like, hey, it's most likely not TB, like if there's no sign of abnormalities. But just know you cannot use a x-ray alone, because an x-ray, you might see some things, and you probably will if they have active tuberculosis. But even if someone has active and I'm trying to check if they have active versus latent, I can't look at an x-ray and be like, oh, this is definitely active. The only definitive way is a sputum specimen. So let me give you for instance, like if I had a patient with active tuberculosis, we do a TB skin test. It's going to be positive. We do a T-spot. It's going to be positive. But those two are also both going to be positive if it's latent. So how do I tell the difference between active and latent? So I might get a chest x-ray, and that's going to tell me maybe, hey, look, there's actually some stuff going on in here. It's probably active, but let's do a sputum specimen, because that's the only way we're really going to be able to tell between latent and active. They have to do 3 consecutive specimens in order to get a diagnosis, and this can take weeks because this bacteria does take a little while to grow and show up. It can take up to 6 weeks sometimes for definitive results. But just keep in mind, with the sputum specimen, this tells us what's growing right now in our sputum. So if I have an active infection that wasn't encapsulated in my lymphatic system, this will show up as being positive. So what does this patient look like? They usually start to have symptoms about 2 to 3 weeks after they've been infected or after reactivation. That reactivation is when it's latent and is becoming active. And what's going on or happening there, again, is my immune system is weak or something's going on that is causing those encapsulated bacteria to open up. And get let out into the wild. So the patients, usually the early symptoms they're going to have, and anytime you think of early symptoms, you always want to think of mild symptoms. Usually the early symptoms are things that aren't as serious. You're going to look at things like loss of appetite, fatigue, or lack of energy. They may have a dry cough, which is usually that first symptom to appear, kind of a prolonged dry cough. But the hallmark symptom that usually differentiates this compared to others is going to be night sweats. So this tends to be something that is more specific to tuberculosis. But you can see they have a lot of similar symptoms to other disorders. So you always want to look for what are those things that are different. So late, if it's not caught early, and again, you have to think about some of the population that gets this or is more at risk, people in prisons, nursing homes, and the homeless. They may not notice it or have the cognition to, or, have the same resources. So that it's possible people can show up this way. But if they're coughing up blood, which is also known as hemoptysis, or if they're having difficulty breathing, this thing has got them pretty good. And it's a later sign where it's more serious. So we definitely want to pay attention to those symptoms. So with tuberculosis, what the signs that they're getting better or worse all have to do with infection and breathing. So they're getting better, they're going to have signs that their breathing is better, they're having less difficulty with their infection wise, like less of a temperature, their sputum culture having multiple negative cultures are going to be signs they're getting better, whereas the signs that they're getting worse would be like, of course, signs that the infection's getting worse. If their symptoms are worsening, if they have a new or worse fever, lung sounds are starting to get involved or starting to have dyspnea, things like that, because it's either worse infection or worse respiratory problems, because that's effectively what lung infections are. We got an infection issue, and that infection issue can cause a breathing issue. So tuberculosis can spread to other organs. At my school, we don't talk too much about the miliary TB, but it can also cause lung problems like pleural effusion, which we talked about with pneumonia. So if you have any questions about that, you can always go back to that lecture. It can lead to respiratory failure. So for that, we're going to look for signs that they're not getting oxygen well, and things like that, like I was talking about on the last slide. You're going to look for any sign that their work of breathing is getting worse, or that they're showing signs that their body's not getting perfused or not getting good oxygen, like their SpO2, their blood gases. You're going to maybe notice it in their capillary refill and in their flow to their other tissues. And also can lead to sepsis, which is a systemic infection. So for this, we're going to look for changes in blood pressure and changes in mental status to see how things might be different. And so the changes in blood pressure would be a drop in blood pressure, and then they can have like a decreased level of consciousness or confusion. So how do we treat tuberculosis? There's, there's a variety of meds that can be used, but they're seen as 4 essential meds listed here. We're going to talk about them coming up more individually. But we can use like other medications for the symptoms, like some of the other upper respiratory kind of meds, like we talked about. Like if they're having a cough, we can give them antitussives, things like that. But these aren't really seen as a treatment for tuberculosis. It's just more supportive. Different medications you're going to need if they have drug-resistant tuberculosis. And then again, if they have latent tuberculosis, they're not going to need as much treatment as if they have active. There is combination drugs because these are a lot of meds and they have a lot of side effects, and it's sometimes hard to keep up with everything. So it does help to improve adherence. But most patients with active tuberculosis require around 6 to 9 months of treatment. So this is a long-term treatment. For patients, again, because we have a lot of high-risk patients that might have trouble with compliance, we do what's called DOT therapy, or direct observed therapy. And what this means is that there's a clinic and people can walk into this clinic on a daily basis and they're given their meds. It's to keep them accountable and make sure that they're keeping up with this regimen. Because there's a really big problem with compliance with tuberculosis. So how do I know these medications work? This is just like pneumonia, that if these antibiotics are working, then we're going to see signs that their infection is better and signs that their respiratory status is better. So that's what we're going to look for as a whole when it comes to these medications, is how's their infection going and is their respiratory status improving. So how about problems with these meds? So there can be problems with these meds when it comes to the fact that they are very toxic to different organs. They can lead to a lot of side effects. You have to wonder, like, oh, why is there such a compliance problem? Well, there's a compliance problem because these medications are really hard on the liver, really hard on the body and cause a lot of uncomfortable symptoms. And it's not that you're taking these for a short period of time. You have to take these, sometimes for almost a year for some patients. And so imagine, it's not that every patient has every one of these side effects, but it can be very uncomfortable. And imagine if you did have a lot of these side effects, how that would make day-to-day life harder. And sometimes with tuberculosis, like, you're feeling better, you're not experiencing any symptoms, and someone's saying, yeah, keep taking these meds that are causing all these painful symptoms. But just like all antibiotics, we need them to finish the entire course, or they're not effective and it can lead to more drug resistance. But anyway, getting into it, all tuberculosis meds are hard on the liver. So you want to think about needing a baseline liver function testing to make sure that, see where the patient's at to make sure it's not getting worse. So the first tuberculosis medication is what's known as isoniazid, and so the things with this is just that, again, it's bad for the liver, so don't drink alcohol. But the other thing that's specific about this is that it can cause peripheral neuropathy, or like numbness, tingling, burning in your extremities. And some people have found relief from taking vitamin B6 with this, and it helps with some of the neuropathy or decrease the neuropathy. There's also rifampin, and rifampin can change the color of your secretions, can make them red, orange, or brown. And while this is not like a life or death thing, it freaks people out when their secretions change. So make sure to let them know that their secretions can change colors. And then they also can have what I call the double H, which is hepatitis and hematological disorders with rifampin. So definitely make sure they're aware of that. There's pyrazinamide, and this one increases uric acid, and uric acid can collect in your joints and lead to some extreme joint pain. So you definitely want to try to look for ways to help them with that. If they are accumulating uric acid, they may need other treatments and things for that, but letting them know to report any joint pain if it does come up. And then ethambutol, I always remember the E in ethambutol can lead to eye problems. So this can lead to blindness. So again, these aren't like little things. It's some of these, if you're taking all these meds, potentially you could have numbness, tingling, burning in your extremities. All your secretions are changing colors. Your liver can go into failure. You can have blood disorders. Your joints are hurting, and you can go blind. And again, those are the extreme level of them, but imagine why it might be so hard to get people to be compliant with these meds. So as you're studying these meds, or any med, it's really helpful sometimes to use a table. If you put meds on a table, it can help to break them down. And I don't have one that I can show you right now easily, but it really helps to be able to separate them and look at them like, okay, how is this one different? Like pretty much effectively, you want to have on a medication table, you want to have the med name, you want to include, maybe if it is used for multiple disease processes, what diseases am I using it for? And then you want to kind of break it down like I've broken down meds here so far, which is, how do I know it worked? Is there any special administration stuff that I need to do before, during, or after, like assessments I need to check, labs I need to check, things I need to do? And then how will I know there's a problem? So what side effects? And there's like a lot of meds cause common side effects, GI, headache, but think the ones that are different, or the ones that a patient's going to maybe complain about, or maybe not be compliant with this med as a result. And it's really great, especially when you have a lot of meds, to put them on a table and compare and contrast them. And then, go back through and process it again and mark the things on the list that are different. You can't remember everything about every med, but if you can remember what's different or what stands out, that can definitely help you on an exam. Because, really, when we want to teach you what is expected for these meds, because there's going to be sometimes these meds have symptoms, and it's okay, like the rifampin and the urine color change. But we also want you to know when you need to act and take action for these medications in order to make sure there's no, serious complication. So medication tables are great. Flashcards can work too, but I think sometimes the medication table, especially when you have medications for one disease process, and really like process how each of them is going to help and connect it back to the disease process. Anyway. All right, so other medical treatments. We want to support good oxygen and ventilation. So oxygen therapy, they may need respiratory treatments if severe. And I talked about this with pneumonia, like steroids, bronchodilators. These don't really treat the tuberculosis, but they can improve comfort sometimes. This is not a swollen airway issue, where the airway needs to be opened. But sometimes, because the mucus and other things, if it's severe, it can help to have that little bit of openness. But again, these are not mainstay treatments. They're going to be in airborne isolation, which, most people talk about, goggles, gown, gloves, and stuff. But really, the only two things that you need for airborne isolation are an N95 and a negative pressure room. And so that's a room that keeps bacteria from spreading out into the hallway, other rooms, etc. So it keeps those particles in. The patient is going to be infectious for first 2 weeks after starting treatment. So this is from the start of their treatment, not from the start of their symptoms. We also want to make sure to manage infection by good oral hygiene to make sure not to spread the bacteria. We want them to have good nutrition, so foods high in calories and nutrients are going to be key, and we're going to give them support by making sure that, we're checking on their pain at regular intervals. They could have, some chest pain and stuff with coughing, kind of like with pneumonia, but they could also just be generally uncomfortable or have aches, fevers can be uncomfortable. So we can do things like give acetaminophen. So as the nurse, my goal is to, I'm going to have similar goals. I want to get their secretions up. So I'm going to encourage fluid intake and thin secretions. I'm going to support good oxygenation by checking on their respiratory status often, and then support their ventilation as well, and oxygenation by keeping their head of bed up. For infection management, teaching really good health habits like hand washing, adequate rest, avoiding crowds and those with infections. And here's something that's different from tuberculosis from pneumonia. This is that for tuberculosis, it's considered a public health concern, and we track the prevalence of it. So we have to notify the health department when we have someone with tuberculosis. So we want to encourage small, frequent meals, the good bang for your buck, where sometimes these patients might have trouble breathing and eating at the same time. And so we want to encourage them to eat well and eat those highly nutritious foods. And we can also bring them comfort by repositioning. Now, like tuberculosis is a lung infection. It can cause some difficulties, but generally, again, unless it's very serious or very late, a lot of these patients don't have severe like respiratory distress, or they need to be intubated. Like with pneumonia can get really serious really fast. With tuberculosis, just it depends on the patient and their immune system. But just know that, these patients are usually going to be on oxygen. They may need some support, but, they're not necessarily always going to be like in an incredible distress that you'll see much more often with pneumonia. If they are, that's definitely something you want to watch. Anyway. So some teaching, because anytime you hear that there's a compliance issue with a disease process, you want to think that my job as the nurse is to teach. So you want to teach them they have to have 2 negative cultures before they're considered not infectious. They need to stop, the spread the best that they can by covering their nose and their mouth with tissues when they cough, sneeze, or produce sputum. You want to tell them how important it is to adhere to their medication regimen. Even when they're feeling better, they need to finish that treatment. And then they need to know the symptoms of tuberculosis if they didn't really note them, especially the first time. What is it going to look like if this ever came back, especially if they have latent? Because with latent, remember, there's no symptoms. So with latent, you want them to, you definitely want to teach them about what their symptoms are. So that way, if they've never experienced that, they wouldn't know what to look for. Anyway, that's the last one. We've got a few more fun disorders to come. I'll see you for those.